Okay, so I am Dr. Carolynn Young. I am a gynecologist. I started Rockville Gynecology about 12 or 13 years ago. And there are a few things that I am very, very passionate about. One of them, for those of you that know me, are taking care of women with fibroids and heavy bleeding. But the other thing that I care about so much is assessing people's risk of breast cancer. And so I was really excited when this product came out, which we're going to talk to you about in detail, because it's really helping us figure out who do we need to worry about in terms of being at elevated risk for breast cancer, and what can we do to try and prevent or find cancer early and cure it. And that really goes to the motto of Rockville Gynecology, which is power in prevention. So about 1 in 8 women in the United States, actually in the world, will develop breast cancer in her lifetime. And I think it's important to realize that that's 1 in 8 women will develop breast cancer. That doesn't mean 1 in 8 women will die from breast cancer. So really important to remember that. What are the major risk factors for breast cancer? We're going to go into a lot of these in more detail, but just in general. Age, we know that the older you are, the higher the risk of breast cancer. Ethnicity, white and Black women have the highest risk for breast cancer. Body mass index, in general, being overweight or obese increases your risk. Menopausal status increases the risk. How dense your breasts appear on mammogram, the more dense increases the risk. And then women with a family history of breast cancer. So I wanted to spend just a minute to debunk some myths about things that we are exposed to that have been shown to not increase the risk of breast cancer. And those would be abortion, most chemicals such as pesticides, antioxidants, having your tubes tied does not increase your risk of breast cancer. Luckily, caffeine does not, because I enjoy coffee every day. Electric blankets do not increase your risk. Breast implants do not. Hair dyes do not. And being around microwave ovens do not. So that's all good news. Risk factors for breast cancer. Obesity, especially in postmenopausal women, is a risk factor. Just being tall. Tall women have a higher risk for breast cancer. Benign breast disease. So if you ever undergo a breast biopsy and it comes back benign, just having had that biopsy does put you at a higher risk for breast cancer. And it's really not the biopsy itself. It's just the fact that there's something going on in your breast tissue that increases the risk of breast cancer. So in terms of hormone exposure, I have so many patients that worry when they take birth control pills, if they're putting themselves at higher risk for breast cancer. And the answer is yes, but just a tiny bit. If you're under age 35 and you take birth control pills, there's 1 extra case of breast cancer per 50,000 women per year. So it's very minimal. If you're over 35, it's 1 in 7,500 women per year. So these are very, very small numbers. And hormone replacement therapy, if you use it for 5 years, and this is estrogen plus progesterone, there are 3 additional breast cancer cases per 1,000 women in that 5 years of use. So yes, it increases the risk just a little bit. The good news with both of those, though, is once you stop taking birth control pills or hormone replacement therapy, your risk will go down to baseline within 5 years. So it's not, it doesn't confer an increased long-term risk. You're also at higher risk for breast cancer if you get your period early, or if you have no children or you have them after the age of 30. If you've undergone chest radiation, for example, if you've been treated for Hodgkin's lymphoma, you're at much higher risk for breast cancer. Night shift work has actually been associated with an increased risk for breast cancer. And then dense breasts, as we'll talk about more. So in terms of when you get a mammogram, there are 4 categories of breast density. So entirely fat, scattered fibroglandular densities, heterogeneously dense, and extremely dense. And about anywhere from 45 to 50% of women have this increased breast density, meaning they're in the heterogeneously or the extremely dense breast tissue. It does increase the risk of breast cancer a little bit. If you have heterogeneously dense breasts, it's equivalent to having a second-degree relative that has breast cancer in your, if you were to, in your family history. So that would be an aunt or a grandmother. If you have extremely dense breast tissue, in terms of risk, it's equivalent to having a first-degree relative with breast cancer. In addition, if the tissue is really dense, then the mammogram doesn't work as well to find abnormalities. So it's more difficult to find abnormalities in women with dense breasts. So moving on to family history and genetics, only about 5 to 10% of breast cancers are associated with the BRCA or the BRCA mutation, which most people are familiar with. Another 10 to 15% other genes can influence the risk of breast cancer, and different family cluster genetics play a part. But really, about 80% of breast cancer is sporadic. And there is no family history. So I have so many patients that say, well, I don't have a family history, so I'm not worried. And I have to just share with them the statistic: 80% of women who do get diagnosed with breast cancer do not have a family history. So you really can't feel reassured. If you have a hereditary or a familial risk of breast cancer, such as the BRCA mutation, the chance of getting breast cancer earlier on is much more elevated, whereas women who have sporadic breast cancer tend to develop later in life. I also do want to spend just a minute talking about who should be tested for the genetic mutations, such as the BRCA. It's really, if you yourself have been diagnosed with breast cancer, you're a candidate. But if anyone in your family, in a first or second degree relative, so that's your parents, grandparents, aunts, uncles, siblings, and children. So in that group, anyone with breast cancer under the age of 50, breast cancer in 2 or more relatives on the same side, maternal or paternal, bilateral breast cancer, so that breast cancer in two different breasts, breast cancer in any male, those are all candidates for genetic testing. In addition, if there's a family history of ovarian or pancreatic cancer at any age, you're a candidate for testing, or uterine cancer or colon cancer diagnosed under the age of 50. And there is a predisposition towards having these genetic mutations in Ashkenazi Jewish population. So anyone that has Ashkenazi Jewish ancestry and basically has any type of cancer in any relative is really a candidate for testing. So if we look at the BRCA mutation, or these hereditary genetic mutations, only about 1 in 400 women in the general population will carry one of these mutations. For women with Ashkenazi Jewish ancestry, it's actually 1 in 40. That's why it's more important in that population to be testing frequently. But in terms of hereditary mutations, 1 in 400. Contrast that to 1 in 5 women in the general population will have a combination of common genetic and clinical markers that will elevate her risk of breast cancer and put her at high risk and change our management. So that's 1 in 5. And what we're trying to do is figure out who's that 1 in 5, because that's such a high number, and we really need to know who do we worry about in terms of breast cancer and who do we not worry about so much. So what we're talking about tonight are something called single nucleotide polymorphisms. And these are common genetic markers. They're changes in your DNA. These are completely different from the genetic mutations that we talked about before with the BRCA mutation. So everybody has SNPs. We call them SNPs, single nucleotide polymorphisms. Some of them actually protect from breast cancer, and some of them increase your risk of breast cancer. So if we look at different people, this patient may have a couple of pink SNPs, and that's her risk. And this one may have some more, and this one may have some more. So everybody has the unique fingerprint of what their SNPs look like. If we look at how does this affect breast cancer risk, we know if you have a genetic mutation like the BRCA mutation, it has a really big impact on risk. Up to 70% of women can get breast cancer. And if we compare that to some of the intermediate mutations that we do detect on these big genetic panels for the mutations, CHEK2 or ATM is another one that's really common, has a moderate impact on risk. And then SNPs are really common. And if you have one SNP that increases your risk of breast cancer, really that's no big deal. But if you have a lot of them, it really changes your risk level. And I tried to liken this to a boat. So trying to understand SNPs and the BRCA mutation, if you have a boat, we just don't want it to sink. We want to go out and we want to enjoy it. Now, in this correlation, I don't want you to think sinking is death. And really sinking in this illustration is getting breast cancer. We really don't want that either. But if you have a BRCA mutation, it's like having a big hole in your boat. And so you're having a fountain in the front of your boat when that's making it very difficult to stay afloat. The SNPs, in contrast, are like tiny little holes in the bottom of your boat. And if you had 1 or 2 holes, you could just put your feet over it or put something over it. No big deal, go on and everything is fine. But if your boat is full of these little holes, you're at higher risk for having it sink, and which would be at higher risk for developing breast cancer. So all of this plays a part. Diet, exercise, your body mass index, it's all part of the picture in terms of developing breast cancer. Like I said, breast cancer increases with age. So about 70% of women are 55 and older when they develop breast cancer. And we do know that, having your period earlier or having children later in life, all that plays into the risk for breast cancer. So really the questions, do you want to know your underlying common genetic risk? If you do know it, then you and your doctor together can make proactive decisions to adjust your screening to reduce your risk of developing breast cancer. So I want to talk about understanding risk. It's so important to remember, if you're at high risk, that does not mean you're going to get breast cancer. It just means that you're at higher risk for it. So really important to remember that. My dad used to say, or taught me when I was young, do not ask the question if you are not willing to accept the answer. So I did some crazy things in my teenage years because I did not ask the question. But I think about that even now when I'm ordering diagnostic testing. I only want to order something if it's going to change my management. So this is it's a tricky topic. I want to know my risk of breast cancer, but I want it to be low. But you can't have it both ways. So you have to be willing to accept that your results might show that you have a higher risk, and you have to be okay with that and accept that, and know that there are things that you can do to adjust screening and lower risk. So you really have to know, what are you going to do with the information before you ask the question. So combining risk factors together, we can predict a woman's risk of developing breast cancer. And that's looking at her personal risk factors, family history, and then these SNPs. And all together, they're all pieces of a puzzle. They give the risk-reducing options and whether or not she's a candidate for additional screening. So before GeneType, which is the company, the test that does the SNPs, was available, really there were 2 models that we used to assess the risk of breast cancer. One is called the Gale model, and the other is called IBIS, which is also called Tyrer-Cuzick. And in these models, which you can look them up online, you put in the patient or your age, your ethnicity, how old were you when you had your first period, your first child, whether or not you've had a prior breast biopsy and what were the results, and then family history of breast cancer, to give it a 5-year risk and a lifetime risk. And the Tyrer-Cuzick is a much more detailed score, and it includes a much more detailed family history, including second-degree relatives and even more distant. It also takes into account breast density from mammogram. And it also looks at your height and your weight and your age at menopause. So it puts that all together to give us a risk. So what's the definition of high risk? With these two models, Gale and Tyrer-Cuzick, the lifetime risk of breast cancer of 20 or 25% or higher is considered high risk. Now, again, that doesn't mean these people are going to get breast cancer. It just means they're at a higher risk. The other thing that you have to remember is that if you come back with a lifetime risk of breast cancer of 10%, that doesn't mean you're not going to get breast cancer. It just means you're not a candidate for additional screening. And the baseline recommendation would be a breast exam once a year and a mammogram once a year, basically starting at 40, earlier if you have a family history of breast cancer. But the other part of high risk is calculating what's your risk of getting breast cancer in the next 5 years. And most of the national societies think that if your risk is 3% or higher, then you are a candidate to take medicine to decrease your risk. If your lifetime risk is 20 to 25% or higher, then you are a candidate for additional imaging, and that's usually a breast MRI. If you're in this high risk category, we actually do recommend doing a breast exam with a provider every 6 months, considering an annual breast MRI. MRI is a wonderful, very detail-oriented study. It's complementary to mammogram. So mammogram can find things that breast MRI can't find. Conversely, breast MRI can find things that mammogram can't find. But I try to make sure patients understand that if the breast MRI is normal, then we're happy that everything is fine. However, if it comes back abnormal, that just means we would recommend an MRI-guided breast biopsy, and most of those are actually not cancer. If the 5-year risk is 3% or higher, then the patient is a candidate to start different medicines to decrease their risk. And then if they're at very high risk, especially if they're a BRCA mutation carrier, there is the option of a risk-reducing bilateral mastectomy. So comparing GeneType to this IBIS, which is Tyrer-Cuzick, this genetic risk assessment, if we look at the number of women that we figure out who are at high risk, the GeneType actually can find 9 times as many people that are at high risk compared to the IBIS score. And the women who are classified as high risk with GeneType have a much higher incidence of breast cancer compared to the women that are at high risk with IBIS. So it's really just showing it's the next level of assessment. All right, so who's not a candidate for GeneType? It sounds awesome, like we should all do it. So really you have to be 35 and older. So women under 35 are not a candidate. Women who've already been diagnosed with breast cancer are not a candidate. And really this is, remember, you don't ask the question if you're not prepared to accept the answer, or do something. Women who've had breast cancer, we already know they're at higher risk. So they're in a whole different category in terms of how they're followed. And again, women who have a genetic mutation that increases their risk, such as the BRCA mutation, we already know they're in a high risk category. So GeneType wouldn't change anything in terms of how we're going to manage them. But GeneType can really help you uncover your underlying risk. A lot of times we just see personal history, family history, and we're just seeing the tip of the iceberg. But looking at the SNPs in your actual GeneType really can help us see what's underneath, what's deeper, and how does that affect our overlying risk. What can all of us do to decrease our risk of breast cancer? There is some data that eating a Mediterranean diet decreases your risk, and so that would be high in fruits, vegetables, fish, and olive oil. We should minimize red meat and processed meat. A high soy and phytoestrogen diet has actually been shown to decrease your risk of breast cancer. Conversely, a high fiber intake, exercise is wonderful. Breastfeeding will lower your risk of breast cancer. If you are postmenopausal, there are studies showing a low-fat diet will lower your risk. And then limiting alcohol. We know that alcohol is associated with an increased risk of breast cancer. This is super sad to me because anyone that knows me, my family and friends, knows that I love a glass of red wine, especially pizza and red wine on a Friday. It makes me so happy. But the studies really show that we shouldn't be drinking much alcohol. Anything over 3 drinks per week has been shown to increase the risk of breast cancer. 2 drinks every day doubles your risk of breast cancer. But there is good news. Studies show that if you take folic acid when you drink alcohol, it actually minimizes the damage that the alcohol does on the breast tissue. So there isn't a set dose, 400, 800, 1,000, somewhere in there. So whenever I have my red wine on Friday and Saturday, I take a folic acid to hopefully minimize that risk. And I also want to just put a plug in for moderation and let's enjoy life. So if this is something that you love, I'm not here to tell you to not ever drink alcohol. I'm just want you to be wise about how it can affect your health. In general, women should not be having more than 7 alcoholic drinks per week. I'm going to use myself as an example. When this came out, I was 44, so this is 8 years ago, and it was called Brevigen Plus. So the name of the test was a little bit different. I have no family history of breast cancer. I did have 1 prior breast biopsy in my early 40s. It was benign. So I'm thinking I'm cruising. I'm fine. I'm not at high risk. I did the Gale model at that time. Remember, I'm 44. It showed that I have a 15.8% lifetime risk. Remember, high risk is 20 to 25% or higher. So I'm thinking we're good. And a 1.7% 5-year risk of breast cancer. Again, we're good. But I said, let's do GeneType, which was Brevigen back then. And it's a saliva test now. Back then it was a little cheek swab. So we sent that in and it looks at currently 83 different SNPs. So a whole bundle, and they're about ready to change and upgrade the assay to include 300 and over 300 SNPs. So if you look on the right-hand side, it'll say calculated risk versus population mean. So every SNP that you see that is over 1 is increasing my risk of breast cancer. And every SNP you see that is under 1 is lowering my risk. So it's looking at all of these genetic changes. And it gave me, on the left side, you see a risk stratifier of 1.65. So that's my Brevigen or GeneType risk stratifier. 1.0 would be neutral, like my genetics, my SNPs are not changing anything. Anything above 1 is showing that you're at a higher risk for breast cancer, and anything less than 1 shows that you're at a lower risk. But what we do is use either the Gale model or the Tyrer-Cuzick model. And in this case, we use the Gale model, and my risk remember, I was 44, my risk was 15.75% lifetime risk of breast cancer. Remember, I was all happy. But we multiply it by my risk stratifier, 1.65. Now my risk is 26%. So I just bumped from low risk to high risk. So that's how it helps us understand, like, oh, shoot, now I'm in the high risk category. Should I start getting breast MRIs annually? Conversely, if you look at my 5-year risk, it was 1.67%. You multiply it by the 1.65 risk stratifier, and now my 5-year risk, remember, this is when I was 44, was 2.76%. So breast cancer risk, as we mentioned, increases with age. But what's cool is the GeneType risk stratifier does not change. So if we do this test on you, it's one time, your results are done forever. So then I recalculated my risk as I was putting this presentation together. Now I'm 52, and I use the Tyrer-Cuzick model. I think it's a little bit better at predicting. So my 5-year risk now is 3%, and that's because my age went up. We multiply that by 1.65, which is my GeneType stratifier, which doesn't change. Now my 5-year risk is 5%. Conversely, my lifetime risk just on age alone was 24%. Multiply it by 1.65. Now my lifetime risk is up to 40%. So I just want you to see how, even for me, this changes how I need to be managed. And like you can see where it's time for a breast MRI. Like, this is really important. I'm 52, I'm perimenopausal. Do I go on hormones? Do I not go on hormones? Like, maybe I shouldn't go on hormones if I know I'm at a significantly higher risk for breast cancer. And then now my 5-year risk is over 3%. Should I start taking tamoxifen to decrease my risk? I might, but these are important things that I need to discuss with my healthcare provider. But I just wanted to show, I think this is a fabulous example of how, like, in real life, how does this really change? So the question is, do you want to know your underlying common genetic risk? It gives you a deeper understanding of your personal risk factors. It's just a easy saliva sample in the office. And it's really helpful, especially if, we were to do the Gale model or the Tyrer-Cuzick and you're running around 20% lifetime risk. GeneType is super helpful. Like, it might bump you up, it might bump you lower. If it bumps you lower, then we're happy, and we just say an annual mammogram, annual clinical breast exam. Now I think everybody should have this because it's such important information to help me figure out who's at high risk, but especially patients who have, let's say their mom had breast cancer at 51. So they don't meet criteria for the genetic mutation panel testing. But really, 51's young, and I want to know, like, how much do I need to worry about this actual patient? So I really feel like this is taking a giant step forward in helping us understand our individual risk and what we can do to change that. So if you want to schedule an appointment for testing, you can just go to rockvillegynecology.com. If you are an existing patient, just send us a portal message that you're interested in scheduling an appointment, and we will reach out to you. If you are a new patient, then just fill out the tab to pre-register as a new patient, and we will call you and set up an appointment, and it's easy as it can be. Now, I do want to mention that these tests are run in Australia right now. So it's about a 1-month turnaround. And that's all I have, but I am more than happy to answer any questions. All right, I'm hearing, Lex, how did you decide to send me the invitation to the webinar? All right, so I sent this invitation to everybody that had ever registered as a patient at Rockville Gynecology for anything. So that's how you got the webinar information. And I'm so happy. Thank you for all of you who are able to attend tonight. All right, if you've already been diagnosed with breast cancer, can you still have the test? Just to know. Again, it doesn't change the management. So I would say I wouldn't recommend that. I would just follow up with your oncologist and your breast surgeon and your GYN in terms of how you should be managed after you've been diagnosed with breast cancer. I'm happy to take any other questions. If anyone wants to write anything in chat, or you're welcome to unmute yourself. You don't have to show your video. Not everyone has to show video. It's okay. I'm shouting out to my mom, Nancy Saucier. She's the one with the horse. She's a horse lover. She's also joining us from Denver. Love you, Mom. All right, John, do you want to wrap us up? Oh, how long does it take to get a result? About 1 month. 1 month. Is geographic area taken into account? So it is not And you're exactly right, because there are certain areas that are at higher risk for breast cancer based on where you're living in the world. That is not taken into account with this test.